Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders. I'm Chris the Chi Man Chu, and I'm joined by two amazing people today. I have my good friend, Dr. Sam Mazer. Hello. And our producer, Hartley Litsky.
Hello, hello.
Did I say that right?
Yes.
Excellent. Our guest tonight is Dr. Matthew MacCarthy to discuss cerebral palsy. But first, Sam, tell us about the show.
We are the Pediatric Medicine Podcast. We interview leading experts in the field to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation tonight with our guest, Dr. Matthew MacCarthy. He is a specialist in pediatric rehabilitation medicine, currently in Columbia, South Carolina. He himself was diagnosed with cerebral palsy at 6 months old, and he is deeply honored to be able to serve children with CP using both medical expertise and lived experience. He wants everyone to know that pediatric rehab focuses on function in everyday life for children with disabilities, so coordinating therapies, bracing, equipment, medication, all to help children function as independently as possible. Outside of medicine, Dr. MacCarthy identifies as a huge nerd, and he really enjoys video games, fantasy, Dungeons & Dragons, and a cappella music.
I think the folks will really enjoy this episode, so everyone have a nice stretch and dig on in. All right, and we're back. Hello, Dr. MacCarthy. Thanks for coming on the show.
Absolutely, my pleasure.
So first, we're sort of an informal group. Is it okay if we call you by your first name? Is Matt okay?
Yep, 100%.
Excellent. So we're going to start off with some warm-up questions, just to get to know you a little better. First, could you, tell us a little bit about yourself and maybe something that you do outside of medicine?
Yeah, so my name is Matt MacCarthy. I am a physician in pediatric rehabilitation medicine, also known as Pediatric PM&R. I am currently based in Columbia, South Carolina at Prisma Health. And for those who don't know, pediatric rehab primarily works with children with disabilities. I know that tonight's topic is cerebral palsy. That is one of our bread and butter areas of patient care, also muscular dystrophy, other neuromuscular conditions, and helping kids recover from catastrophic illness or injury. I love what I do. I also have cerebral palsy, so I have both the lived experience and the medical expertise in this particular topic, and that's what drew me to pediatric rehab medicine in the first place, taking care of kids that I was in their position when I was younger. It's awesome. I love it. In my free time, I play a lot of video games. I play a lot of tabletop games. I play a lot of collectible card games, namely Magic the Gathering and Dungeons & Dragons. So I'm a huge nerd, and I also... Well, I don't have an outlet currently, but I have a huge history in a cappella music in college and med school. I'd love to get back to it. I haven't found an outlet yet here, but I'd love to sing again.
Fantastic. Harley, you want to go next?
Yeah, I'm curious. So I'm a medical student, and I love to hear from people maybe the best advice you've ever received, either in training or now as an educator. What advice sticks with you?
Yeah, so I can't think of any singular piece of advice, I guess, from a purely medical framework, like nothing clinical or anything like that. Instead, what sticks with me, when I was a medical student, my advisor told me to find one thing outside of school that keeps me alive and passionate, meaning something not related to medicine that I enjoy and that keeps me, refreshed. And for me, that was singing. I think for a lot of medical students, it becomes way too easy to focus 100% of your time on school, because I think all of us were type A, especially academically, and the jump in challenge from college to med school is enormous. So you're like, I have to spend all of my time studying and I can't do anything else, but you'll burn out. So I did a lot of singing in med school. And then sort of surprisingly in a similar vein, when I was a fellow, I remember a day that morning clinic ran way over. And so I just jumped straight into afternoon clinic. And one of my supervising attendings said, "Did you eat lunch?" I said no, because the last patient encounter ran over. And she was very much into self-care, but she said, there is, other than codes and rapid responses, there is absolutely nothing that is so urgently in need of our attention that I can't take 5 minutes to put food in my mouth. And that has stuck with me since then. Like, if clinic runs a little bit late, at least I am taking care of myself, because I can't take care of patients if I'm not taking care of myself.
Yeah, I mean, one of the tough things is it's always the setting those expectations. It feels like the expectations are the highest for every single person at every single moment, and that's one of the things that we constantly battle with, and so the expectations that all of a sudden all these patients, need to be seen the exact same, but they're seeing a wonderful customer service industry. No, they're seeing you as a doctor, as a professional, who is, we all have to remember to care for ourselves. That's a really good point. Not to mention, of course, the finding something that makes you passionate and happy outside, because, again, burnout is real, and we all talk about it as we go on this podcast. So thank you. Thank you for that.
Yeah, I think this is sort of where you sort of see some of the hidden curriculum too. If you start seeing your attendings and stuff model, like skipping meals just so they can get through things, and it sounds like you have, you had attending who modeled good behaviors. Like, no, go eat. I think that's also important too.
Yeah.
Factor meals are back, Cribsiders listeners. Make this your best season yet with nutritious 2-minute meals from Factor. Eating well has never been this easy. Just heat up and enjoy, giving you more time to do what you want, whether it be on a busy clinic day, seeing patients in the hospital, or trying to exercise with your limited time. Now, get outside to do what makes you happy instead of prepping and cooking indoors. Factor meals arrive fresh and ready to eat, perfect for any active lifestyle. With 45 weekly menu options, you can pick gourmet meals that fit your goals. Choose from Calorie Smart, Protein Plus, Keto, Veggie, and more. Factor powers your day with satisfying breakfasts, on-the-go lunches, premium dinners, and guilt-free snacks and desserts. It's easy to savor more this spring. Factor meals pack in the flavor with none of the fuss. I highly recommend the Cacio e Pepe. So easy and so tasty. So, Cribsiders listeners, get started at factormeals.com/Cribsiders50off and use code Cribsiders50off to get 50% off plus free shipping on your first box. That's code Cribsiders50off at factormeals.com/Cribsiders50off for 50% off plus free shipping. That's a great point. I was going to ask about how you got into pediatric PM&R, but you obviously gave that answer already. I feel like we should just move directly to the cases.
I agree.
Hartley, would you mind reading our first case from Cashlack Children's Hospital?
Absolutely. So our case for tonight is Caleb Jones. He's a twin infant who you are seeing for an 18-month well child visit at Cashlack Children's Outpatient Clinic. Caleb was born at 32 weeks via emergency C-section after PPROM with fetal bradycardia. He and his twin brother both spent 2 months in the NICU for sequelae of prematurity, including respiratory distress syndrome and slow oral feeding, although he didn't go home with oxygen or a tube feeding. His parents tell you that he started crawling only recently and he still isn't able to pull himself to stand with support, which is concerning to them because his brother is already walking independently. They also noted that Caleb seems like he's left-handed and he rarely uses his right arm to play with toys or pick up food. On your exam, Caleb is crawling around the exam room. He's interacting with his parents to try to get a toy that he wants. He makes eye contact with you, he starts crying, and he starts reaching for his parents when they lift him onto the exam table. You notice that the muscles on his right side feel a little tighter than his left side with decreased passive range of motion. So, Matt, if it's okay, would you be willing to start with the basics and just tell us a little bit about what is cerebral palsy?
Yeah. So, cerebral palsy, first of all, I think the number one thing to understand about it is that it is not an etiologic diagnosis. And what I mean by that is that it does not point by itself to a specific thing that happened. Instead, it's an umbrella term that we use to describe a pattern that we see with very early brain injury. So there are 3 things that you need to be diagnosed with cerebral palsy. One is damage to the developing brain, either before birth, during the birth process, or within the first few years of life, depending on who you ask. Consensus is usually around 2 years. Number 2 is that it's non-progressive, meaning it doesn't get worse with time, and that's important because there are congenital neurological conditions that do get worse with time. And number 3 is that it causes a disorder of movement and posture, or how I phrase that to parents is difficulty controlling the muscles. And if you have those 3 things, you meet criteria for cerebral palsy. And if that sounds like it could be a bazillion different things, that's because it is a bazillion different things.
My first question is, you're going through some of those things to make a diagnosis. How does one determine what is considered brain damage?
That's a good question. So really what it comes down to is, well, sometimes we have evidence of the injury. So commonly, just off the top of my head, the really common causes, depending on kind of the body area affected, neonatal stroke is one of the common causes. Intraventricular hemorrhage is one of the common causes, and hypoxic ischemic encephalopathy, which is common among our micropreemies, where they don't have enough respiratory effort at birth and there's an ischemic insult. So in those cases, we know that damage was done to a certain area of the brain or to the brain globally. There are other cases where we don't necessarily know if there was a specific inciting event that did damage to the brain, particularly because the number one sort of diagnostic modality in CP is brain MRI, but that's only abnormal in 85 to 90% of cases. So most of the time you're going to find something on MRI, but there are cases that are diagnosed clinically that you don't ever find abnormalities on imaging. And so it's then based on clinical presentation and usually some manner of risk factors like prematurity, like as in this case, multiple gestation is a risk factor, infection, coagulopathies, things like that. And then apart from that, there is the consideration of genetic syndrome or genetic factors. So I say damage, and this is somewhat, depending on who you ask, you'll get different opinions. But the presence of things like polymicrogyria, where the bumps in the brain are smaller than they should be, or other genetically based brain malformations, if the clinical presentation is consistent with cerebral palsy, meaning they have a movement disorder that doesn't change with time, most of us would still call that CP, although there are some that say, no, that's genetic. That means that it's not CP.
So just to talk a little bit about the symptoms, because I think I'm starting to understand what you're talking about here. This is a true umbrella term because anywhere you can get brain damage is anywhere you can have symptoms. Mm-hmm. Nevertheless, can you kind of walk us through kind of one of the most common symptoms we're talking about from a motor perspective, and then we'll talk about how we layer on the kind of the alternate, kind of the other cognitive pieces.
So just from a motor standpoint, by far and away, the most common manifestation is going to be spastic or spasticity. So spasticity is the condition. Spastic CP is how you would describe it. From a learner's perspective, I always say, if you're going to see CP, you're going to see spastic CP. That's just a good place to start. So spasticity, very briefly, is a velocity-dependent increase in muscle tone, which basically means, like Hartley was saying earlier, so when we describe kind of tight extremities, that usually goes into you feel resistance as you're passively moving a joint. And with spasticity, it's velocity dependent. So in terms of exam findings, the faster you try to extend the elbow or the faster you try to dorsiflex the ankle, the more that resistance kicks in. And if it's severe enough, you're going to feel resistance regardless. But if the spasticity is mild, you might only feel it if you're really moving the joint quickly. And that part is sort of analogous to clonus, except for it's not rhythmic. The resistance will be sort of continuous. The other motor manifestations are umbrellaed again under the dyskinetic forms. So dystonia is very similar to spasticity, except for it kind of comes and goes as opposed to being relatively static. And then we get ataxic, choreiform, and athetoid, which chorea is similar to like Huntington's chorea. You have these dance-like movements that you have to differentiate what's purposeful and what's not purposeful. And then athetoid is also uncontrolled movements, but it's smaller amplitude and sort of a writhing. So spasticity, again, 80 to 85% is spastic. Then you have the other forms, and then there can also be what we call mixed type, where there's manifestations across multiple different movement disorders, which all of that in addition to what may or may not, like the non-movement associated things and spectrum of severity within each of those categories plays into the massive spectrum of CP. I have started telling my families there are essentially as many manifestations of CP as there are people with it.
Yeah. I mean, I can only imagine, right? Because when I think of it, it feels like easier to conceptualize in my brain about the stroke component. And okay, if I have a ischemic event in any single different part of my brain, I can get a different motor response in every single part of my body.
Right.
And so I could see it a bazillion different ways. But let's take this case, for example, that Hartley pointed out that we don't know automatically this kid had something. It's not like, as you said before, that, hey, we have this automatic thing. We already got a head ultrasound, whatever it may have been, a brain MRI. What are some of those early signs and symptoms that should make the general pediatrician start to think about CP and kind of work our way backwards?
Yeah, I love this question. So the kid in this case, the biggest area of concern from parents is that he is not using his right side. So hand preference typically develops somewhere between 18 months and 2 years. It is not inborn. And so all of these developmental milestones have a little bit of wiggle room on either end, where the phrase I always use is nobody reads the textbook, right?
Yeah.
So a few months earlier than that or a few months later than that is probably fine. But if you're seeing a 6-month-old who is only moving one side, or like a 1-year-old, like meaning 12 months, big red flag there. And then the other, there are also red flags on history. So this kid has all of them: prematurity, twin birth, 2 months in the NICU, that kind of thing. But in terms of clinical presentation, things that we can look at early on, hand preference is one of them, like I mentioned, and then crawling pattern is the other one. So the kid in our case is probably going to end up with what we call hemiplegia, where you're affected on either the left or the right side. And in this particular case, he's crawling, but most of the time with hemiplegia, they instead of going from sitting independently to crawling with what we call a 4-point creep, where they have hands down and knees down, they end up scooting. So they sit on their bottom and they use their functional side to scoot themselves across the floor. So that's a red flag. And then for diplegia, which is where you're affected in both legs and then both arms are relatively functional, usually their crawling pattern is what we call commando or army crawling, where they use their hands or their elbows to pull themselves across the floor and the legs are just kind of dragging behind. So I will say that early developmental, like early meeting milestones, can also be a red flag. That's a little bit harder to parse out. But if somebody comes into the office and the parents are super proud because the kid is 6 months old, and if they put them down on their feet, like against support, and they can stand independently, that might be of concern, because some of my kids with CP have elevated muscle tone in their quads, and that's how they maintain independent standing.
Gotcha. Yeah, I mean, it seems almost similar to the handedness thing that you're talking about, right? Look, yeah. Oh my God, you can write with the right hand. Actually, you're not supposed to do that.
Right.
Right, yeah. From there on.
That's super interesting. I would never have thought of early milestones as something to think critically about, but that's a wonderful point. I want to talk more. You mentioned already that CP is kind of an umbrella term, and there's multiple different etiologies that can cause CP. And I think a lot of us are familiar with some of the more common risk factors like prematurity and birth trauma, etc. But can you talk through some of the other risk factors that we may not be as familiar with?
Yeah, absolutely. So the big three are probably prematurity, coagulopathy in either direction, so bleeding disorders or clotting disorders, and infection. And I think that a lot of people who have a more surface level exposure to CP will say that it is a disease of prematurity. I know this is getting a little bit away from risk factors, but I just wanted to say that prematurity is a huge risk factor, and you're 10 times as likely to be diagnosed with CP if you're below 28 weeks. But more people in the world who end up diagnosed with CP were born term than were born preterm, just from a sheer numbers perspective. So prematurity, infection, and coagulopathy are the big three, and then there are a bunch of other ones. So maternal infection or fetal infection, so chorioamnionitis. I always have trouble saying that word. The torch infections can play a role. Maternal health history is important, so diabetes, multiple sclerosis, there are a couple other things that raise your risk. And then, unfortunately, socioeconomic status is also an independent risk factor. Primarily income, education, and occupation, which there are various theories why, primarily related to like access to healthcare and sort of understanding of the importance of prenatal care.
Yeah.
Racial disparities has been shown to also be a part of that. The interplay there, I'm not sure, in terms of like it's obviously a very complex thing.
Yeah. And thanks for bringing that up too. We try to highlight that on the show, kind of at least where these disparities lie, so we can know about it, and then we can recognize, wherever our bias might come in, and try to take better care of these children. I did have another question about the risk factors, though. You mentioned infection. Are you referring to just meningitis, or is it literally any type of infection from a when you're, we'll call it neonatal fever and any of the things that come with it?
Yeah, so I don't know if, as far as I know, neonatal sepsis is not an independent risk factor unless you're talking about then respiratory failure and kind of leading into some of the other causative things like hypoxia, ischemia kind of deal. I know that the torch infections are a risk factor, and then chorio, but not the more sort of general systemic or urinary or more focal infections in the neonatal period.
Yeah, like the 7-day-old that spikes a fever and we find out they have GBS bacteremia,
right.
And we put them on our treatment regimen and go kind of through that pathway. That's not what we're referring to. It's
Correct.
more anything that would affect the brain, or if they were getting so sick that they were so poorly perfusing the brain, maybe that's what we're
Correct.
referring to too.
So one question I have is, especially when you look at the current case that we have here, we have an 18-month-old child visit, but possibly some of the issues that might have led to this presentation might have happened much earlier on in this patient's course. And of course you said that, whatever brain damage that you might see from multiple etiologies can happen all the way to, for some people, maybe up to two years of life. What's the common age range that we may start seeing these and thinking about diagnosis? Because I would say obviously it takes a while to see development and so forth. Is this typical to see a child come in at, a year and a half of life to actually finally present some symptoms that as a result of something that might have happened while at birth?
Yeah, absolutely. And that's actually part of the conversation that I, as a rehabilitation specialist, have with families in the NICU. So, as an example, we have a micropremia in the NICU with confirmed hypoxic ischemic encephalopathy based on early ultrasound and early brain MRI. And so the risk is huge, but we don't have a confirmatory diagnosis yet. I will tell the parents, this is what we're looking for. This is what I'm monitoring for. Like, here's what cerebral palsy is. Here's why your baby is at risk. But we won't know until later, because from a motor perspective, newborns aren't supposed to be doing anything. And so typically the earliest diagnosis, you're talking about around 6 months, and 18 months is definitely not atypical. The leaders in the field are trying to push that earliest diagnosis earlier to like 3 or 4 months. In my anecdotal experience, earlier diagnosis is not super critical as long as you recognize the risk and they're already plugged into services. So I think the push for earlier diagnosis is primarily so that we get kids plugged into services, but I will do that anyway if there's a risk. So there are various tools and scales to use for early diagnosis, one of which is the really well confirmed and validated one. It's called the Hammersmith Infant Neurological Exam, which requires in-person training that I haven't found a workshop for yet. That is on my to-do list. But the short answer to your question is no, 12 or 18 months is not atypical in terms of diagnosis. I would like it to not go much further than that, just so that we can get therapies in place. But yeah.
Do you feel like you can never get ahead of charting? Imagine a world where you don't need to think about notes again. Introducing Freed, an AI medical scribe built to free clinicians everywhere. It listens, transcribes, and writes instant clinical notes for you in your style. Freed can be used across all specialties for in-office as well as virtual visits, and it works in multiple languages. Written in your style and ready the moment the visit is over, all you have to do is copy it into your EHR. Freed is HIPAA compliant and only takes seconds to learn. Over 15,000 clinicians, including doctors, APPs, and therapists, use Freed to save up to 2 hours every day and free themselves from documentation. Just imagine the great feeling of coming home without any notes hanging over your head. Get back to doing what you love and let Freed do the rest. Start your free trial today. No credit card needed. Use code CURB50, that's CURB50, to get $50 off your first month when you subscribe.
Yeah, I want to talk about, I imagine putting myself in a parent's shoes, having that first conversation, maybe if they haven't met you in the NICU at 12 or 18 months, learning that something that happened over a year ago maybe affects my child's health now might be a little bit confusing or jarring or just unexpected. Can you talk through how you approach that initial conversation with a family that you maybe haven't met before, suggesting that CP might be something that you're concerned about in their child?
Yeah, so the first question I always ask is, have you heard the term cerebral palsy? So, and then that's a good into the conversation, because I generally I hear parents say they mentioned that in the NICU if there were risk factors, or I've never heard of that with him, but I have a friend of a friend, or, I saw it on TV one time, or they've had some kind of exposure to cerebral palsy, which, by the way, in terms of this weird, arbitrary umbrella term thing, is why it's so helpful to continue to use that term with families, because it has greater penetrance in society than most of this other really esoteric, medical diagnosis stuff. People have heard of it. And so you have an in with the conversation there, or they will have heard nothing ever about it. So based on that, I then go and say, well, we do or we don't have risk factors from his or her history. And if we don't, then I say, usually this comes with being born early or having something happen to the brain super early on when we don't know when exactly it happened. Usually we know to look in those kids, but sometimes that gets missed if they were born full term and otherwise doing fine. And the problem with that is usually that with the mild cases, you don't necessarily know to look until they're doing more sophisticated things from a motor perspective. And so I explain what it is, we did a minute ago, with damage to the brain, trouble controlling the muscles. And then from there, it's just empathy. So kind of explaining why I'm concerned about CP, what the risk factors may have been, or did we just miss it because the kid was otherwise doing well, and now they're being challenged more in terms of more sophisticated milestones, and we're just seeing it for the first time. But in those cases where there's never been a conversation earlier, and they're just now hearing it, I try to frame that as a positive, because if we've gotten to this point and you're just now seeing it because they're being challenged with more sophisticated milestones, that is almost a guarantee that it's really mild.
Yeah.
And then like I said, empathy. So do my spiel, and then I say, that was a lot. This diagnosis is always a lot. I'm done talking. Where are you at?
And I could imagine that their next question is like, well, how do you know? Is this, did we diagnose it already? What test do we need to do? How do you know this is CP? You just told me that we had something that might have occurred when he was born. How do we know? Is that usually kind of the next thing? / that's also my question.
Yes. That is usually the next response. And I can think of one kid that I saw recently who was sent to me at 2, who had seen his pediatrician and then been sent to orthopedics for toe walking, but it was unilateral. And so various interventions later, stretching, physical therapy, casting, still walking on his toes, only on one side. And with the more benign forms of toe walking, it's always, at least in my experience, going to be bilateral. And so that was red flag number one. He's only doing it on one side. I framed that into the conversation that we kind of just covered, and the parents were very mad that, like how did we miss this? What's going on? And so I'm like, to be honest, I don't know what happened. In a lot of these cases, we don't know, especially in the kids that didn't have NICU time and were otherwise well. And the likelihood is that we'll never know exactly what happened. Now, I can help confirm the diagnosis by ordering a brain MRI, which is what I did. And then he had periventricular leukomalacia, which is damage to the white matter tracts around the ventricles, only on one side. And so that was confirmatory of the diagnosis. But it was still a conversation of, like, how did this get missed? And so it's just, I try to defend colleagues in those cases. Like, there was never a reason to look. Well, I don't want to say never, but early on, there was not a reason to look. Could they have looked earlier? Yes. But he got into physical therapy, and we did other things that were appropriate that I would have done at this stage anyway. Now that we're having the conversation, we know the trajectory to take. And I always tell people, I'd say it's not necessarily a new diagnosis in terms of something that needs to change. It's a new term and a new way of describing what we already knew was going on. So we have these challenges. The application of the term cerebral palsy frames the conversation in a different way, but the management is usually the same as what they've already been doing.
So one question I have as, a general pediatrician is, if I have high suspicion of a patient to having CP, would I be ordering that MRI? I mean, obviously it's a big thing to, send a little kid to MRI because it usually involves some sort of, sedation. And then, like, who would I also consider sending to for that confirmatory? Because I think you said before, there aren't that many pediatric PM&R people around. So who are the people in most of our communities who will also be helping us manage this? So
to answer the question about ordering the MRI, my answer would be only if you're comfortable. But then if you're not comfortable, or if you just want additional input, right? The people that should always be involved early on, if you have relatively easy local or regional access to a pediatric rehab doc, I would like us to be involved in every single one of these cases. If you don't, or if there are other concerns for, say, comorbid epilepsy or things like that, obviously neuro. And if you don't have access to one of us, like in peds rehab, pediatric neuro is a great, I don't want to say substitute, but they should usually be involved anyway. And then not necessarily in the really early phase, but ortho should usually be involved later on, school age.
And we're going to get to school age in a second, so I actually want to hold off from that because we're going to talk about some of our treatment things. So from a diagnostic standpoint, I just want to complete this whole thought. So, like, it's pretty easy to say, oh, this person has a motor problem, followed up by this motor problem probably hasn't changed. So you're really just looking for that birth or that, that neonatal period injury. Mm-hmm. When you order a brain MRI, are you ordering without contrast, just kind of a stroke protocol style, or are you ordering with and without?
No, just without.
Okay, awesome. Just because I need to know as the primary care doctor as I go to order the brain MRI, right, Chris?
Yeah, and so, that was going to be one of my questions as well.
Without contrast, because you're almost always looking for a remote injury.
Yeah.
In the absence of the rare case where they were developing normally and then the parents are like, he stopped moving one side, in that case it's still going to be without contrast, but you're almost always looking for remote injury.
And, we're about to kind of bring ourselves to our next case, which is getting older. Mm-hmm. Can you just mentioned before we get on there, you had mentioned before about trying to really early refer to, the support specialist. Would you mind just listing kind of who you're referring to right off the bat, and then we can kind of bring Caleb to an older age?
Yeah. So pediatric rehab, that's my personal bias. Always comes first. Neuro, It's always safer to just go ahead and refer to ortho. There are really what I, as a rehab doc, am interested in the involvement of orthopedics is monitoring the hips and spine. But they're never going to say no if you have a suspicion for CP and just send the kid. It comes into how often are we doing hip and spine X-rays because of risks that I'll get into later. But like I said, they're never going to say no. And then almost always you're talking about physical therapy because it's a motor impairment at its core. Mm-hmm. So 99% of the time you're talking about physical therapy. I would say 90-ish% of the time you're talking about occupational therapy. And then speech therapy is a little bit of a different beast early on because I know we're in the process of switching to school age, but speech therapy under or around a year, we'll see kids if there are concerns about feeding difficulty. Working on language usually they won't do anything with language until usually about 2. So you have more time as their provider to kind of monitor and like say, what is their language doing? Because if it's developing normally, then you might not have to refer. But if at 2 they're not meeting the typical language milestones, you want to get speech therapy involved as well.
One quick question. So you said, most will get PT, almost most will get OT. We have a lot of, learners who are on the show. Can you, and I feel like this ends up being a little black box because we get a lot of people say, refer to PT-OT. Can you at least, in a couple sentences, explain what the difference between PT and OT is?
Yeah, and I apologize for not doing that a second ago. So physical therapy and occupational therapy, just to be clear what we're talking about without the acronym. A lot of times physical therapy gets associated with like the legs and occupational therapy gets associated with the arms. You can fairly accurately divide it up like that. There's also physical therapy primarily works on gross motor and occupational therapy primarily works on fine motor, but there's also upper extremity gross motor. So PT kind of does both. Another way to phrase it, and this is usually how kind of what the frame of reference that I use when I'm referring. Physical therapy is gross motor and mobility. Occupational therapy is fine motor and like self-care. So if they have difficulty with, and this is always you want to consider what's age appropriate, right? But with like dressing or bathing or eating, not in terms of the oral stuff, but like getting the food to the mouth, that's all occupational therapy. And then mobility and getting around is PT.
Awesome. Perfect. We've been teasing this for a little bit. So let's make Caleb older. Hartley, if you wouldn't mind reading the case here as Caleb gets older.
Absolutely. So Caleb, we met him at 18 months. He's now 6 and he's about to start kindergarten. So he did get home PTOT and he did start cruising around 18 months and walking around 2 years using orthotics. Right now he uses a right leg brace when he's around the house and then a walker or a wheelchair for longer out of the house activities. He ended up being diagnosed with mild hearing impairment, so he wears hearing aids and does get speech therapy. He has learned to read and write with his left hand, but he started to have a little bit more pain and spasticity in his right hand, and it's now impacting his daily life. So I think at this point, we'd love to talk a little bit more specifically about how to treat spasticity and pain in CP, both from a medications perspective, a non-medications perspective, and then a procedural perspective.
Yeah. So there are a bunch of different antispasticity medications. For the sake of this conversation and for the sake of brevity, the first line interventions, enteral medication-wise, are going to be baclofen, which is a GABA B receptor agonist, and then the benzodiazepines. I primarily use either clonazepam or diazepam. My personal first line is baclofen. There are other providers who will go for the benzos first. The potential downside of baclofen is that it can theoretically lower the seizure threshold. So sometimes in kids with comorbid epilepsy who have very poor seizure control, I will either go straight to the benzos because if anything, it's going to help with seizure control, or I will at least check with their neurologist whether they're comfortable with baclofen. I've never gotten anyone to say no, so that's an indication of kind of how not problematic the theoretical lowering of the seizure threshold is. But So baclofen and the benzodiazepines from an enteral perspective. And then from a non-enteral/procedural perspective, we do a whole lot of botulinum toxin injections. And so does pretty much everyone in my field. Neurology can do it as well. And I know some orthopedic surgeons that will do it. The decision point there for me is how widespread is the spasticity and is the pain. I will say that pain from spasticity is relatively rare, thankfully. You usually just get the muscle tightness and it doesn't otherwise bother them, although depending on how widespread it is and what otherwise their functional level is, you may consider spasticity control that doesn't have anything to do with function. I'm primarily looking at spasticity control from a functional perspective, but for some of our much lower functioning kids, sometimes spasticity control from a care perspective is also important. Like, it's super hard to change their pants because I can't pry their knees apart because the spasticity in their hip adductors is so bad. But enteral I primarily use for more widespread spasticity, and then sometimes I'll go straight for botulinum toxin if the spasticity is focal. So, as an example, for Caleb, if his discomfort and his spasticity is primarily in the right elbow flexors, which are your biceps brachioradialis and brachialis, depending on what position of the forearm you're talking about. But if it's primarily there and he doesn't really have any difficulty functionally or pain-wise elsewhere, I'm definitely going to go straight for botulinum toxin because it's disadvantageous, especially in kids, because it's a shot and nobody likes shots. But it's advantageous because it has no systemic side effects and it only affects the muscle that I put it in. And for the enteral stuff, they're muscle relaxers, so they're going to affect every muscle in the body. And often, not always, but often, in addition to the extremity spasticity, a lot of these kids have central hypotonia. So they have low muscle tone in the neck and trunk, and some of the more systemic muscle relaxers can adversely affect that, especially early on when they're learning to sit up and things like that.
I have so many questions, but I'm going to start as kind of one at a time here. Let's start with the botulinum toxin because we're right on it. Would you mind just kind of walking us through how that actually works? Like a little bit of the pathophysiology and physiology behind it?
Yeah. So botulinum toxin, the brand name that I use is Botox, and a lot of people refer to it as Botox, but Botox is a brand. So the generic is just botulinum toxin. And it's the same toxin that's produced by Clostridium botulinum that causes botulism if you have a systemic infection. So there are, I believe, 7 different subunits of the toxin. We use 4 or 5 of them therapeutically, depending on the brand of injectable that you're talking about. All of the different brands are a different subunit of the toxin, which gets really confusing. But all of them interfere with different elements of the SNAP-SNARE complex, which is a protein complex that facilitates presynaptic fusion of acetylcholine vesicles. So basically, it's a neuromuscular blockade. You're drastically reducing the neurotransmitter release from motor neurons and thus blocking the motor response. So spasticity is really just an elevated and sort of constant motor output that is due to abnormal signaling in the brain and spinal cord. It's moderated through the muscle stretch reflex in the spinal cord, same as clonus. I know I mentioned earlier that the velocity dependent component that goes with clonus, where you have to like jerk the ankle and then it'll kick back against you. That's because of the muscle stretch reflex in the spinal cord, where you get a sensory input at the level of the muscle to the spinal cord, and then like sensory afferent and then motor efferent. Except for with spasticity, the motor that signaling pathway is sort of constantly being excited. We don't know really specifically how it works, but we know that it's moderated through that.
Yeah. No, that's perfectly helpful. And then how often do you need to give the botulinum toxin? What's the frequency if you're giving injections? We'll say it works.
Yeah. So the textbook response is 3 months. The real response is that it varies by kid. On average, it lasts about 3 months. I've gotten as short a duration as 6 weeks, unfortunately, and as long as 5 or 6 months. The kids that last 5 or 6 months, I love them because I don't have to do it as often, which is great for the kid, great for me, great for the parents. We cannot do it more often than every 3 months because the data shows, and I can't point you to a specific study, but just the literature shows there's an increased risk of antibody formation if you do it more often than every 3 months. And that's across indications, unfortunately. So some of these kids, not to get into associated stuff, but they also sometimes get it for drooling. You can put botulinum toxin in the salivary glands to help with drooling, and we often have to coordinate with ENT because you can get it on the same day or maybe a day or two apart for salivary and for muscular, but I can't do mine and then have ENT do theirs a month later, or we're risking antibody formation, which is not dangerous in and of itself. It just increases the risk that you don't respond to the medicine.
Can you speak a little bit between how you pair your botulinum toxin injections and maybe splinting or orthotics, and how you use those together in patients for their management?
Yeah, we do that all the time. So, as with Caleb, he's like school age right in the most recent part of the case and now walking with an orthotic, which is most likely an ankle foot orthotic or an AFO, which encompasses the foot. The definition of an AFO, it's like imagine a piece of plastic that goes around the foot and the ankle, and then plastic up the back of the calf to just below the knee. We do that super commonly because one of the common, I won't say universal, but super duper common issues with gait deviation in cerebral palsy is toe walking, because it's very, very common to have spasticity in the calf, and so the calf muscles, namely the gastrocnemius and the soleus, are going to plantar flex your ankle, push your toe down, and then you push up on the knee or push up on the toe. And depending on what else is going on, those kids either hyperextend their knee, or if they can't quite get their knee straight when they're walking, then you get what's called jump knee, where you come down on the toe, but your knee is bent, and then they like pop it back. So bracing wise, in order to get control of ankle plantar flexion, you need the long lever arm of coming up to below the knee. There's a different brace called an SMO, or a supramalleolar orthotic, that just encompasses the foot and the ankle, but the part in back is not long enough to control plantar flexion. You have to come up to below the knee to control it. So I'm talking about like tangentially related things, but oftentimes I will do Botox in the gastrocnemius and or the soleus to help the plantar flexion spasticity to either help fit the brace more easily, because a lot of these kids, you put them in a brace and then they push out of it because they can't relax that muscle. And it also then will help their gait mechanics, because even in the presence of the mechanical control of a brace, if you have muscle tone that's not being controlled in the calf, that lends itself to deviation at the knee and the hip. And then we also do it frequently coupled with casting. I do that when kids start to lose range of motion. So this is like, we haven't brought this up yet, but spasticity decreases a kid's ability to control motion in the opposite direction of wherever the spasticity is. And then coupled with the fact that they're kids are growing. So every single one of us, neurotypical or otherwise, when we're kids, bones grow faster than muscles do. So if you're doing the normal kid stuff and running around and playing and climbing and whatever, you naturally stretch your muscles out to the point that muscular growth keeps up. But if you're dealing with spasticity that's pushing a muscle into a certain position, and then the bone that muscle is attached to is also growing, it's a setup for muscle contracture. So these kids lose range of motion unless we're really aggressively stretching, and I push that at every single one of my visits. So if they get to the point where you can't dorsiflex at least to 90 degrees, which is necessary to stand with your heel flat, then usually what I'll go to is called serial casting, where I do Botox to alleviate the spasticity, and then send them to a physical therapist that will put them in a cast, and then it's usually for a week. Put it on for a week, take it off for a week, put it on for a week, take it off for a week, put it on for a week, take it off for a week. And in between, they will dorsiflex the ankle as far as it'll go and cast them in that stretch position, so that instead of having like, okay, hold this stretch for 2 minutes 3 times a day, you're getting 24/7 stretching for a week, which is really good at gaining range back. It's the most aggressive thing that we can do short of surgery. And in the case of CP, I mean, there are other indications, but in the CP population, it's always more effective with Botox on board.
Awesome. That was an awesome answer for Botox, combining it with the orthotics and the casting. If I wouldn't mind going back to your medicines, as I said, I did have a lot of questions. So I was wondering how you could kind of walk through how you would dose baclofen. Like, how do you give baclofen? How are you dosing it? How are you titrating up? And I'll talk to you. My follow-up questions will be about safety in a second, but I'd love to hear where you start.
Yeah. So this is my personal style / lexicon and up to date. So you'll get some variability between practitioners, but expert opinion, correct. I start at 0.5 milligram per kilogram divided twice a day. Baclofen is often prescribed either 3 times or twice a day or 3 times a day, sometimes 4 times a day, but it's usually either BID or TID. So I start at 0.5 milligram per kilogram per day, divided BID, but I start with the nighttime dose for a week because there are a number of different side effects of baclofen, but the most common is sedation. So I always start with the nighttime dose because if then they get sedation, then it's time to go to bed anyway. And if they don't, great. So start with 0.5 milligram per kilogram, and then I work up by, it kind of depends on how like the urgency of needing to control the particular kid's spasticity, but usually I'll like increase by 50% of whatever their starting dose was a week at a time. So,
and at what point do you, go on. Yeah.
And then the typical, I don't know if I can even give a typical therapeutic range because everybody responds to it differently, but I would say the typical therapeutic range is between 1 and 2 milligrams per kilogram per day, divided either BID or TID. There are people in my field who have been talking about, because when I was in training, the like theoretical maximum was 2 milligrams per kilogram per day. I often nowadays will push it past that because for number one, we found out that some kids need more than that. And number two, there's not a lot of safety risks, or I shouldn't, like there are pretty much no major safety risks. You'll hit your quote unquote maximum when you start to see side effects. And that's almost always that kids get sleepy.
And then at some point you were saying, you must add in benzodiazepines if you're saying, hey, I'm not getting the therapeutic effect I'm looking for. Do you add in benzodiazepines after you've reached 1 to 2 mg per kg per day, or do you add them in earlier as you're kind of titrating both up at the same time?
No, I always try. So personally, I always shoot for monotherapy if I can get away with it. So I'm increasingly willing to push past that 2 mg per kg per day. But if you're getting, and the difficulty with this, right, is that you kind of you typically hit your max dose when kids get sedated on it, like daytime sleepiness. And I'm unfortunately not going to add a benzodiazepine because that's just going to make it worse. So if kids are maxed out to the point that they're getting side effects, then I either will do Botox on top, which I do pretty frequently, or there are other considerations, like if you are kind of at the max dose of baclofen and you're not getting good enough control, neurosurgery can put in an intrathecal baclofen pump. It requires very careful patient selection and a very robust care system to make that successful. So very briefly, it's a subdermally implanted pump that they like underneath the abdominal skin, then they thread a catheter through the abdominal cavity into the spinal canal, and you're pumping baclofen directly onto the spinal cord. There's a lot of potential risks and things that can go wrong. So my preference is always to have, like I said, a very robust care system behind that. We unfortunately don't have that set up in where I'm at currently, but I did fellowship at UPMC, and the neurosurgery department has an entire team that's basically just doing like follow-ups and pump management, and with appropriate management and a care team, and then with appropriate patient selection, that procedure can be very successful.
And obviously, as primary care doctors, we are not putting in an intracathedral pump, but know, just as the conversation's going, right, they're going to see a PM&R doctor at that point. The thing I am curious about is these kids, as you mentioned before, they might have more injury than Caleb here, but have hypertonia in the lower extremities with spasticity, have hypotonia, especially centrally. Once we relax those muscles, we start to run into some respiratory issues, mostly from the fact that we, can't expand our lungs the way we're supposed to. Right. Is that a side effect that you run into frequently? How do you manage that issue? Or is that something that's usually past your sedation problem?
I have not frequently seen that. Like you said, I think it's you're going to get that after you get sedation. So, which is kind of good from my perspective and from the general practitioner's perspective, right? This is not something that I would generally worry about with up titrating. You're going to have daytime sleepiness a long time before you're going to get any respiratory compromise or anything else that's potentially really serious.
Yeah. Awesome. I think those were probably my questions about how I'm going to prescribe baclofen later on. Yeah. No, I'm kidding. I will refer to everyone to you, Matt. But again, if they don't exist, if your practice doesn't exist in whatever state or country, wherever you might be, at least we can have some level of a starting point.
Yeah.
Amazing. So I want to move us forward in time a little bit. So we met Caleb at 6. Now he's 14. He's doing well in school. We've managed his spasticity with baclofen and botulinum toxin injections in his right arm. He does want to talk to you about some occasional urinary incontinence and some constipation. He's been taking some stool softeners, but otherwise he's doing well and he's excited to start high school. So can you talk us through, we've talked a lot about motor manifestations of CP, but can you talk us through some of the comorbid conditions?
Yeah. So there are a lot, unfortunately. Visual impairment is kind of almost going head to toe. So visual impairment, we can see. Hearing impairment, we can see. And these are kind of dependent on what the causative etiology was. But visual impairment, hearing impairment, oral motor impairment, either from a speech and language perspective and or from a feeding and management of secretions perspective. So I get a lot of drooling and a lot of speech impairment. Voiding and constipation issues are super common. So you just mentioned those. And then reflux is also common with these kids. Epilepsy. So can't remember the percentages. It kind of depends on the source that you're listening to. But roughly 50% of kids diagnosed with CP will end up with some kind of seizure burden. Chronic pain can be an issue, sometimes from spasticity, but often from contracture and other musculoskeletal things. And then cognitive impairment. So cognitive impairment is a big soapbox issue for me because it is common, but it is not universal. So depending on the source that you're listening to, between 50 and 70% of kids with CP have an IQ below 70. But there are plenty of folks that have completely normal cognition, and it sounds like Caleb is right there with us. And it's a soapbox issue for me because I have CP and I have normal cognition, but also because it is there's a huge societal bias, I think, that kind of, and I haven't been able to figure out where it comes from, but people see folks who move differently and they assume that they think differently also. And so untraining that from, hopefully training preventatively, but either training preventatively or untraining learners has been a big thing for me. And just kind of general advice to general practitioners and other subspecialists that will overlap with this patient population.
I do want to touch on the cognition piece a little bit, just especially this is a important topic. Do you refer all your patients to psychology early on to get certain types of cognition testing, or do you just let them go through school and let school kind of work through all the pieces that may or may not come up?
Yeah, so I start with school. If it's glaringly obvious, right, for some of our kids who have like quadriplegia where they're affected, I mean, Caleb, it would be referred to as hemiplegia, so he's affected on the right side. Quadriplegia is both arms and both legs where your motor manifestations are, and those kids tend to have more of all of the things. So they tend to have more of all of the associated things that I just said, and they're much more likely to have some degree of cognitive impairment. So in the kids where it's very obvious, like, we're school age and we're not talking yet, or we're not tracking, or we're not interacting with the environment in lots of meaningful ways, then obviously, we have to have a conversation with the school about, a special education classroom or a self-contained classroom or whatever. But for the rest of them that kind of are cognitively intact or cognitively, mostly per your evaluation intact, what I'll usually do is just say, start school when you are comfortable or when you otherwise would for a normally developing kid. And then the teachers are usually my first point of contact in terms of like, they'll come back for follow-up and say, teachers have brought up concerns about like he's not picking up things at the rate of his peers, or, you know, there's a concern about a specific learning disability in reading or math or things like that. And then if there are identified concerns, then I don't know about the universality of this, but most developmental pediatrics offices or practices have access to neuropsychology testing to do more in-depth testing in terms of, and how I phrase that to parents is, we're looking at strengths and weaknesses. So it's not academic testing in terms of here's a vocab list, fill out the vocab list. But it's verbal reasoning and nonverbal reasoning and abstraction and sequencing and attention and all these other things to identify how does this kid learn best? And then they do a very in-depth report that then gets kicked back to school and say, how can we structure an IEP to do our best for this individual child to make them successful?
Awesome. It's so super useful to understand sort of that process and how that what hopefully will happen at schools. So staying with schools. Schools are a social place. And, you know, I have many patients, you know, and we're talking about Caleb, who's now 14. And, you know, he probably also, as a child, when he was younger, probably also had to deal with the fact that, you know, he may be asked questions from other kids that because he does things different, you know, and, you know, may need, you know, he has mobility aids that other kids may not have. How do you talk to children and their parents about how to empower them about their condition and how to discuss this with their peers? Because definitely I know some teachers are better also at explaining this to the other classmates than others. So like how do you help them through this?
Yeah, so my answer to this is going to be different than a lot of people, right? Because I can share my own experience. I compare braces with kids. Like, your braces are so much cooler than mine. Mine are just plain black and yours have dinosaurs all over them. Things like that. But from a more accessible kind of general everybody advice, I think that it comes down to, in my head, it comes down to sort of three broad areas. And one is to find friends. Because, and this like, so I mean, hopefully that's already happened, but talking, if it hasn't happened, like, you know, kind of exploring what's gotten in the way of that. Are they really shy? Are they embarrassed? And like, you know, just sit with somebody else at lunch, or like walk up at recess and say, can I join the game? Or, you know, things like that. But number one is find a friend, because even if you can find one person that doesn't judge based on appearance, then worst case scenario, you have the rest of the class versus two people and you have a defender, right? So it's now everybody versus two instead of everybody versus one. But best case scenario, you then have an inroad among the normally developing peers to have that one person be like, hey, like, I mean, they move differently, but who cares? And so like kind of bringing the rest of the class over to that side. Number two is how to talk about it, like with the kid. And so obviously this gets more sophisticated as they get older, but even really early on, you know, kindergarten and first grade, what have you told people when they ask you questions, or like what kind of questions do you get and what do you say? And it's, you know, my brain doesn't talk to my muscles, so I move differently. Or I was really sick when I was really, really little, and now that makes me move differently, and I have this brace that I need to use to walk. And I find that a lot of, well, so people fear what they don't understand, right? And that fear can lead to curiosity, or it can lead to judgment. And I think a lot of times the judgment, unfortunately, is a learned behavior, either from parents, peers, or some other external influence. But you have to turn the judgment into curiosity. So, like, teaching the kid how to talk about it can lead to, okay, now I understand a little bit. Now I'm going to ask more questions, or now I'm like not going to care as much. Even if you can just like get the slightest little explanation. So that's number two. And then number three is turning it from a problem into an advantage. And what I mean by that is, like, I'll say, you know, did you know that you're a cyborg now because you have braces? Like, you're artificially enhanced. That's so cool. Or like, talk to me about your superpowers. Or, you know, like I don't know. This is not relevant to anything, but I can dislocate my left thumb at will. So I'm like, I have a superpower. I could do like party trick or whatever. Or, for the kids that aren't ambulatory, you say, I bet you're super fast in your wheelchair. You're like faster than all the other kids. So it's kind of trying to reframe things positively.
I love that. Love that. Shall we ask a little bit about puberty then? How do we discuss puberty as these patients get older, and what type of special considerations do adolescents need to have when it comes to CP?
So, in the absence of comorbid like pituitary issues, which could happen with a general, depending on what area was hit, like a very expansive brain injury, right? In the absence of something comorbid that actually is going to affect puberty by itself, CP in and of itself does not usually affect puberty or pubertal development. And so my response to that, sometimes with the kids with some degree of cognitive impairment, you kind of have to go into more detail about like you're going to start seeing changes in your body, but it doesn't differ that much from the general puberty advice of any general pediatrician, like starting, 7, 8 for girls and 10, 11, 12, somewhere in there for boys, like the anticipatory guidance kind of piece. But what I want to kind of slightly pivot to is sex and relationships for folks with CP, because it's a drastically undervalued and underaddressed area for reasons that are a bit beyond me, but kind of go back to whatever source of societal bias that we have. Nobody tends to talk to folks with disabilities about romantic relationships and intimacy. And I can't remember the exact source, but there's a Dutch study from 2014, I want to say. I don't have it pulled up. I can't remember the year. I can find it for you guys later.
It'll be in the show notes.
They looked at cerebral palsy across the national registry, and this is Dutch. Again, it's not here, but 85% of those kids, including ones that were followed by a peds rehab doc, so one of me, had never spoken to any of their providers about sex and intimacy, because people assume that people with disabilities don't. It's not something that's normal to our lives. And that's just objectively incorrect. First of all, it's incorrect. So, like, advice on sex and intimacy should be the same as neurotypical peers. And even on top of that, I would say that it needs to be a bigger area of focus than typically developing teenagers, because people with disabilities, I don't know about the interplay of cognitive impairment and whether it's an independent risk factor, especially in the presence of cognitive impairment. They're at much higher risk of things like domestic violence, sexual abuse, things like that. I think often because of lack of awareness of red flags. So number one, super important to have those conversations, because those things happen in this population, like in terms of normal romantic relationships, but then even going a step further to really hammer those things home because of the increased risk of unhealthy relationships.
That was amazing. Thank you so much for touching on all of that and for bringing up things that we didn't even think to ask. So super appreciate that. I want to ask about, given that our audience and our production team skews fairly med peds heavy, about transition to adult care for people with CP. As we think about Caleb growing up, what does it look like for him to transition to adult providers, and how do you facilitate that transition as a pediatrician?
So this is a big area of challenge, and I wish I had better answers in terms of how to address it as a field and as a society. I think that transition to adult care, if there are adult rehab docs available, is generally okay, because we get a lot of training even in adult residency on CP, because it's one of the neuromuscular conditions. But in the pediatrics and internal medicine and med peds arenas, it has gotten better, but it's still an area of shortcoming, because I think that despite the best efforts of those of us that I don't want to toot my own horn, but despite efforts from many different parties, it's still largely considered a pediatric condition. And so you guys might be able to speak to this, but have interacted with a lot of different adult providers who don't really know what to do just because they're like, we didn't really get trained on it because it's a pediatric condition. But life expectancy for most, depending on, the comorbid conditions, but for most folks with CP is normal. And so I will, when I'm transitioning them out, first of all, I've gotten hesitant to even do that because of the, I don't want to say lack, but relative difficulty finding a comprehensive care system. Because I think pediatrics is much better at that, at least with CP, than adult medicine is. Like, there's kind of an understanding of, like, they have their primary care, and they have their rehab doc, and they have their ortho, and they have their neuro, and they have all these other folks that are involved. And then you get to adult medicine, and people may be a little bit more hesitant, or it may be a little bit more fragmented. So I've started keeping people to 25, 26. But I start having that conversation at, 16. So we got a long time to figure it out and a long time to help them adjust to the transition. This hasn't happened in my current practice yet, but I also plan on saying, hey, when you go to a different doc, I'm still here. Message me, call me, reach out. If your doc has questions, I'm happy to have a conversation. And so I don't know if you guys want to speak to that in terms of how much training you got on CP in the adult aspect of your residency. I'm curious.
I would say virtually none. I mean, I remember on the adult side, I think I did a PM&R rotation.
Oh, cool.
Where we did a lot of it. Where we went to the local rehab hospital, and I remember doing a lot of injections with not only just patients with CP, but then our patients with stroke as well, sepsis stroke. So, but outside of that, a majority of my CP exposure was on my ped side.
Yeah.
I'd have to say. I don't know if it's true with everyone else.
Yeah, 100% agree. I mean, I think there's a reason why physical medicine rehabilitation is its own residency. And so that's why internal medicine, I feel like the last thing that I was going to get was a pediatric focus of a entire field that I don't think we got trained well in to begin with. I don't think we learned rehab well in the slightest in internal medicine residency. And so, no, I didn't hear a single thing about CP in adult medicine residency.
Yeah. It needs to get better, but that's sort of policy change that's above my...
Yeah, well, honestly, this was our last question. Our last question for you before we took take-home points is going to be, look at this multidisciplinary care that we've been doing. Look at this amazing multidisciplinary support, and pediatrics has really done the great job of this. And from a big picture perspective, how can we help the healthcare system do a better job with this? And I feel like we're touching on this right now. But Matt, if there's anything else you want to add about that.
Yeah, so I mean that was already going to be my number one, is helping to spread awareness and education in the internal medicine arena about CP, because it's equally adult and pediatrics, and there's an entire separate set of considerations with adults, early arthritis, chronic pain, things like that I'm not going to go into too much depth with. But otherwise, I think that just kind of looking into the standards of care because obviously this is what I do kind of day in and day out, but all of general pediatrics and all of internal medicine is going to have some overlap with this patient population because it is the most common motor disability. We say it's the most common motor disability of childhood, but then those kids grow up. So if I can point to a single source you can obviously read, there are tons of articles, there are tons of reference texts, there's all of these summary sources that you can look into and just kind of educate yourself in terms of where the standard of care is at. But in terms of the primary literature, Ayana Novak is an Australian CP researcher. There's a 2019 article called State of the Evidence Traffic Lights 2019, and it's a gigantic systematic review in terms of looking at various interventions for spasticity, for motor control, for gross motor control, for fine motor control, for oral motor control, for balance, for cognitive development, for all these various elements of what CP care is. And they're the evidence, A-level evidence, B-level evidence, so on and so forth. And there's a great infographic that divides things into circles of different diameters and different colors in terms of the strength of the evidence. It's pretty quick to just look and be like, where is the thing that I want to do? And like, how strong is the evidence for it? So I think awareness is the bottom line. Trying to educate ourselves, knowing, that's why I'm always happy to do things like this, because spreading awareness and like a little bit of like pearls and things like that. And then, like I said, try to involve neurology, try to involve orthopedics, and if you can, try to involve peds rehab.
Amazing. So speaking of pearls, I know this is a challenge, but if you could condense everything we've talked about into just a couple take-home points for the audience, what would be your take-home points?
Yeah, so cerebral palsy is an umbrella term, remember? So damage to the developing brain that is non-progressive, that causes a disorder of movement and posture. Care is multidisciplinary, so primary care, ortho, neuro, rehab, orthotists, which are the brace makers, DME vendors, so the equipment providers, and then the patient and the family obviously is at the core. So multidisciplinary care. And then my personal biggest takeaway is assume normal cognition until proven otherwise.
Love it. I want to thank you again for spending an inordinate amount of time with us tonight, sharing your passion for CP care and your own lived experiences, because they were super enlightening. Before we go, I want to give you a chance to plug something. Is there a website or organization that you want, or anything that you want our listeners to check out on their way out?
Nothing comes to mind. If somebody is particularly inspired by this conversation and wants to learn more about the state of care and the state of the field in cerebral palsy, probably the single easiest way to do that is the American Academy of Cerebral Palsy and Developmental Medicine. They have an annual conference every year. Most of it is just CP from every imaginable perspective. You got MDs and PhDs and therapists and advocates and families and like all kind of stuff. They also go into a lot of other developmental medicine conditions, but a huge chunk of it is CP. And so that's obviously only for the folks that really want to learn more, but there isn't pretty much an entire conference every year dedicated to just this.
Perfect. Well, thank you again. We appreciate it. Oh, wait, Sam, what do you got?
No, I was just going to say thank you so much for your time and your effort and the education. I'm ready to go, at least for the first stage before I refer over to PM&R.
Perfect.
Thank you again. Have a good one.
Absolutely.
You have dialed has been changed. The new number is...
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Hartley Lidsky, and our whole team on social media. That includes Twitter and Instagram. So I've been Sam Mazer.
I've been Hartley Lidsky.
And this has been Chris the Chew. Thank you and good night. And for those who have made it all the way to the end, here's another poem written by AI. The title is Caleb's Courageous Waltz. In a world where every step is a bold new dance, Caleb moves with courage, seizing every chance. With legs that sway to their own unique beat, and a smile so wide, exuding joy so sweet. Dr. Hartley Lidsky watches with care so true, finding paths for Caleb that help him pursue. A journey smoother with fewer hills to climb, in a world that dances in its own time. With braces that gleam like armor so bright, Caleb faces each day with newfound might. Therapies that stretch, strengthen, and teach, bring goals he once thought out of reach. A horse that trots, a pull that warmly embraces. Caleb discovers these joyful places. Each session a step, each laugh a joyful note. In his unique dance, how graceful he'll float. With Dr. Lidsky there, steadfast by his side, Caleb's adventures are wide, filled with pride. In a world that celebrates many ways to dance, Caleb's own steps inspire, given the chance. you guys.